The AIOS P. Siva Reddy International Award 2023 is jointly awarded to Dr. Shreesha Kumar and Dr. George V. Putharan. And I would request Dr. Shreesha Kumar to give his talk on double head pterygium excision with modified vertically split conjunctival autograft 6-year long-term retrospective analysis.
Also request the audiovisual to please set the timer to 10 minutes for each talk.
Yes, sir.
We don't want the timer for the session, we want the timer for the talk. So 10 minutes.
Okay. Good afternoon. At the outset, I would like to sincerely thank the Chairman Scientific Committee, Honorary General Secretary of AIOS and members of Scientific Committee and AIOC for selecting me for this honor. It's a prestigious award for the work done on double head pterygium. So many surgeons, they still consider pterygium to be unworthy of their surgical skills and surgical techniques, and this trivialization of the pterygium surgery combined with poor surgical technique is responsible for poor or variable surgical outcome. So the topic for today is the management of double head pterygium. It's a difficult management problem as you have a larger defect to cover, and as such we do not have any set protocol or algorithm to follow. And however, following techniques have been found to be effective in the management of pterygium, double head pterygium. So we have a superior and inferior bulbar conjunctival autografting. You can take graft from the inferior bulbar conjunctiva and the superior bulbar conjunctiva and place it on the bare scleral bed. And it's little difficult to obtain a thin graft from the inferior bulbar conjunctiva because of the adhesion to the tenon's capsule. It's tightly adhered to the tenon's capsule there in the inferior bulbar conjunctiva as compared to the superior bulbar conjunctiva. And this gives good results. And there are occasions where the superior bulbar conjunctiva is not available due to glaucoma filtering bleb, or in a case where you have the patient is a glaucoma suspect, or in case of double head pterygium where you need a larger graft to resurface the bare area on either side of the limbus. So in such cases you can even take a graft from the pterygium tissue itself. The conjunctival sheet from the pterygia can be obtained and it can be placed on the bare scleral bed. Here I am combining conjunctival tissue graft and conjunctival autografting. I am taking a sheet, conjunctival sheet from the pterygium on the temporal side and placing it on the nasal bare scleral defect. And after removing the pterygium from the temporal side, I take a graft from the superior bulbar conjunctiva and place it on the temporal defect. So it can be combined, and we have sent these specimens for histopathological analysis, and it's been seen that a section of the normal conjunctiva had 2 to 4 cell layered epithelium with no dysplasia or malignancy, whereas the conjunctiva overlying the pterygium was found to be uniformly thick with 8 to 12 layers of the epithelial cells and few goblet cells and few capillary networks, but with a similar absence of granuloma or dysplasia, and thus making it a good source of grafting in these cases. And so we published this concomitant use of conjunctival tissue grafts from pterygium itself without rotation in pterygium surgery. So this is done in patients wherein the conventional conjunctival autografting was not possible, and we found this particular technique has been effective in terms of recurrence rate or other surgical complications. It is no inferior to the regular conjunctival autografting, and we compared it with the inferior conjunctival autografting in indicated cases, those with superior filtering bleb or those who needed superior bulbar conjunctiva for future glaucoma surgery. And Both the techniques of inferior conjunctival autografting and conjunctival tissue grafting from the pterygium itself are excellent alternative options with comparable outcomes and no additional risk of significant complications we've seen in both the techniques. Coming to horizontal split conjunctival autografting, here it's a simple technique where you take a large graft and split it into two parts horizontally and place it on the bare scleral bed. So this is a small video showing the same procedure. The limbal end of the graft is placed on the more fleshy nasal defect and the part of the graft which is away from the limbus is placed on the temporal side over the smaller graft, a smaller epithelial defect. And we compared this horizontal versus vertical split conjunctival autografting in the management of double head pterygium, which was a retrospective analysis, and found both the techniques provide good results with comparable efficiency in terms of the rate of recurrence and other complication profiles. Coming to vertically split conjunctival autografting, you split the conjunctival autograft into two parts vertically and place it on the base scleral area. With the limbus to limbus orientation, if you place, you might end up having a gap. There is a bare scleral defect here. It may not be sufficient to cover the entire base scleral area. If you see here, the graft is small here and you have a bare scleral defect here, and this patient ended up with conjunctivalization of cornea. There is a recurrence happening from the lower end of the bare area. And in order to prevent this, you can split the conjunctival graft and slide it down vertically without keeping limbus to limbus orientation. This works well, and I have been doing it for the last 8 to 9 years. And if you see here is the fleshy pterygium, there is hardly any inferior bulbar conjunctiva available. You have enough conjunctiva in the superior bulbar area, and you split it into two parts without changing the orientation of the graft. You just slide it down and place it on the bare scleral defect. Without changing the orientation of the graft, either you suture it or glue it. So we did a retrospective comparative study of vertically split conjunctival autografting for double head primary pterygia, and we included 94 eyes, and the follow-up period was 6 to 70 months with an average of 17 and a half months. And these are the complications we encountered. None of them are very serious complications, and the recurrence rate was just 3.18%. Only 3 out of 94 cases had recurrence. One had a temporal recurrence, one nasal recurrence, and in one case both nasal and temporal recurrence was seen. And when we analyzed, it was actually in 2 of the cases we had graft loss, and in one case we had severe retraction of the graft. We compared it with the other studies. Of course, it's not vertically split conjunctival autografting, but the study for double head pterygium by different authors, and the numbers were much less as compared to our numbers. But the recurrence rate was comparable in these studies. Some of them have done a horizontally split conjunctival autograft, and some have adopted amniotic membrane transplantation. This is our post-op picture of the video which I have shown. And so double head pterygium excision with modified vertically split conjunctival autograft, we followed them up for 6 years, and the results were encouraging, and the procedure is very safe. in these double head pterygium cases where the superior bulbar conjunctiva may not be sufficient. And so we even published one more article in Women Journal of Ophthalmology, similar procedure, but we have used glue here, and the outcome was good. The recurrence rate was less than 4%, and we even compared vertically split conjunctival autograft with and without limbal orientation. That was again published in IJO, and both the techniques resulted in good outcome. To conclude, modified vertically split conjunctival autograft is a safe and successful technique in double head pterygium. Can be adapted in most of our cases. Thank you very much.
Thank you, Shreesh. Thank you for that wonderful lecture, and also thank you for your contributions in pterygium surgery. I know that
Thank
you
you
have
a lot, madam.
contributed a
Actually,
lot. Thank
I
you.
used to present a lot of topics in pterygium, and Dr. Namrata used to be my co-instructor way back in 2003, 2004. I had good number of cases as, for presentation, but no publications. She only told there is no publications at all. Nobody recognizes your work. So since
No,
then I
everybody
started working,
recognizes.
and now I have 19 cases.
Yeah, so everybody
you.
recognizes with P. Siva Reddy International Award, which you are going to get today. Thank you so much.